Welcome to PharmaconHealth. We have all experienced it. Two people take the same medication, same dose, same condition, and one gets better while the other suffers side effects for decades. This was a mystery. Today, we know the answer is written in your DNA. Welcome to Pharmacogenetics, the science of how your genes determine how drugs work in your body. By the end of this video, you will understand exactly what pharmacogenetics is and why it matters clinically, the major types of genetic variation that alter drug response, how 450 separate pounds enzyme polymorphisms change drug metabolism with 3 landmark clinical examples, and how pharmacogenetic testing is beginning to transform patient care. Let us begin. Let us start with the foundation, what pharmacogenetics actually is, and why it represents a fundamental shift in how we think about drug prescribing. Pharmacogenetics is the study of how inherited genetic variations influence an individual's response to drugs, including their efficacy, toxicity, and the dose required to achieve a therapeutic effect. The term combines pharmacology, the science of drugs, and genetics, the study of inherited traits. It is worth distinguishing pharmacogenetics, which focuses on single gene-drug relationships, from pharmacogenomics, which considers the entire genome's influence on drug response. In clinical practice, the two terms are often used interchangeably. Why does this matter clinically? Because standard one-size-fits-all dosing ignores the reality that genetic differences can cause a drug to be completely ineffective in one patient, perfectly therapeutic in another, and dangerously toxic in a third, at the exact same dose. Pharmacogenetics is the scientific foundation of personalized medicine, matching the right drug, at the right dose, to the right patient, based on their unique genetic profile. To understand how genetics changes drug response, we first need to understand the types of genetic variations involved. 3 major categories of genetic variation affect drug response. First, single nucleotide polymorphisms, or SNPs, are the most common type. A single base change in the DNA sequence can alter the structure and function of a metabolic enzyme or drug receptor. Second, insertions and deletions, called indels, involve extra bases being added or removed from the DNA sequence, potentially disrupting protein function entirely. Third, copy number variations, CNVs, occur when a gene is duplicated or deleted, resulting in more or fewer copies than normal. In the context of drug metabolism, extra gene copies can produce excessive enzyme activity, while missing copies reduce it. These genetic variations can disrupt drug response through distinct mechanisms. They can alter pharmacokinetics, what the body does to the drug, meaning how a drug is absorbed, distributed, metabolized, and eliminated. Or they can alter pharmacodynamics, what the drug does to the body, meaning how a drug interacts with its molecular target, such as a receptor or enzyme. In pharmacogenetics, the most clinically impactful genetic variations are those affecting drug metabolism enzymes, particularly the cytochrome P450 family. And this brings us to the most clinically important chapter of pharmacogenetics, the 450 separate pounds enzyme system, and what happens when your genes change how it works. The cytochrome P450 enzyme family, 450 separate pounds, is responsible for metabolizing approximately 70 to 80% of all clinically used drugs. These enzymes, primarily located in the liver, chemically transform drug molecules to facilitate their elimination from the body. Genetic polymorphisms in CYP450 genes produce 4 distinct metabolizer phenotypes, that is, for different functional categories of patient response. Now let us bring this to life with 3 landmark clinical examples, each one demonstrating how a single genetic variant can make a drug dangerous, ineffective, or require a completely different dosing strategy. Example 1. CYP-D6 encodine. Codyne is a prodrug. It has no analgesic activity on its own. The CYP-D6 enzyme must convert codyne to morphine in the liver for pain relief to occur. Poor metabolizers of CYP-D6 cannot make this conversion efficiently, so codyne produces little or no pain relief. They get an ineffective treatment. ultra-rapid metabolizers, by contrast, convert codeine to morphine so rapidly that dangerously high morphine blood levels accumulate, even at standard doses. This has caused fatalities, including in breastfed infants whose mothers were ultra-rapid metabolizers taking codeine postpartum. The FDA now carries a black box warning on codeine for this reason. Example 2. VKORC1 and warfarin. Warfarin is one of the most prescribed anticoagulants in the world, and one of the most dangerous to dose incorrectly. Its effect depends on inhibiting the VKORC1 enzyme, vitamin K epoxide reductase, which is essential for activating clotting factors. Patients with certain VKORC1 gene variants produce a VKORC1 enzyme that is intrinsically more sensitive to warfarin inhibition. These patients require significantly lower doses to achieve the target INR of 2 to 3. Conversely, patients with less sensitive VKORC1 variants need higher doses. In addition, CYP to C9 polymorphisms affect warfarin's hepatic metabolism, compounding the genetic complexity. The FDA-approved warfarin label explicitly recommends considering VKORC1 and CYP to C9 genotyping before initiating therapy. Example 3. TPMT and thiopurine toxicity. Thiopurines, including azathioprine, 6-mercaptopurine, and thioguanine, are used to treat leukemia, autoimmune diseases, and organ rejection. They are metabolized by an enzyme called TPMT thiopurine methyltransferase. In patients with normal TPMT activity, thiopurines are inactivated efficiently and the drugs are tolerated. However, approximately 10% of people carry one non-functional TPMT allele. They are heterozygous and have reduced enzyme activity. Approximately 1 in 300 patients are homozygous for non-functional alleles and have virtually no TPMT activity. In these patients, thiopurines accumulate as cytotoxic metabolites that devastate the bone marrow, causing severe and potentially fatal myelosuppression. TPMT genotyping before thiopurine therapy is now considered standard of care. Beyond these 3 examples, pharmacogenetics is beginning to reshape everyday clinical practice. Let us look at where it is actually being applied and where it faces real obstacles. Pharmacogenetic testing is now clinically validated for an expanding range of drug gene pairs. Beyond our 3 examples, CYP to C19 genotyping guides clopidogrel, the antiplatelet drug, dosing in cardiac patients, because poor metabolizers cannot activate clopidogrel and remain at risk of stent thrombosis after coronary intervention. HLA-B** 57 minutes in 1 second screening before prescribing abacavir, an HIV antiretroviral, is now mandatory in most countries, as carriers of this allele develop a severe, potentially fatal hypersensitivity reaction. HLA-B** 15 OTA screening prevents carbamazepine-induced Stevens-Johnson syndrome in Southeast Asian populations. These are not theoretical applications. They are guideline-endorsed, real-world decisions that pharmacogenetics has already changed. Despite these advances, pharmacogenetics still faces major barriers to universal implementation. Most drug responses are polygenic, meaning they are influenced by multiple genes at the same time, making prediction far more complex than single-gene models suggest. Although sequencing costs have dropped dramatically, pharmacogenetic testing remains unavailable or unaffordable in many lower-income healthcare settings, including much of sub-Saharan Africa. This creates the risk that precision medicine could widen global health inequities instead of reducing them. Even where testing is available, many healthcare providers lack the training needed to interpret genetic reports and apply them to prescribing decisions. Ethical concerns also remain significant because genetic information can affect not only the patient, but also family members, insurance coverage, and employment opportunities. Protecting privacy, therefore, requires strong legal safeguards and reliable institutional frameworks. Despite these challenges, the direction of travel is clear. Let us look at where pharmacogenetics is heading and what it means for patients and clinicians in the years ahead. The future of pharmacogenetics lies in 3 convergent trends. First, preemptive genotyping. Rather than testing gene by gene when a specific drug is needed, health systems are beginning to sequence patients' relevant pharmacogenies once at the point of care or enrollment and store results in the electronic medical record for all future prescribing decisions. The Mayo Clinic's RIGHT protocol and Vanderbilt University's PREDICT program have demonstrated this is both feasible and cost-effective. Second, AI-assisted interpretation. Artificial intelligence tools are being developed to synthesize multi-gene pharmacogenetic profiles, drug interaction data, and patient clinical variables into real-time prescribing decision support. Third, expanded access. The falling cost of next-generation sequencing is making pharmacogenetic panels increasingly available in low- and middle-income countries, where the burden of adverse drug reactions is highest. Let us close with a definitive clinical summary, the core concepts from this video that belong in your long-term clinical memory. Here is your definitive summary. Pharmacogenetics studies how inherited genetic variants, SNPs, indels, and copy number variations alter drug response through pharmacokinetic and pharmacodynamic mechanisms. CYP450 enzymes metabolize approximately 75% of drugs, and genetic polymorphisms create for phenotypes, poor, intermediate, extensive, and ultra-rapid metabolizers. The three landmark examples are CYP2D6 encodine, where ultra-rapid metabolism causes fatal toxicity, VK-ORC1 warfarin, where genetic sensitivity determines safe dose, and TPMT thiopurines, where enzyme deficiency causes bone marrow destruction. Pharmacogenetic testing is already guideline endorsed for multiple drug gene pairs and is moving toward preemptive, whole genome integration into clinical decision-making. If this video deepened your understanding of why patients respond differently to the same drug, please subscribe to PharmaconHealth and share this video with your colleagues, students, and clinical teams. This video is part of our Clinical Pharmacology Series. If you have not yet watched our episode on the therapeutic index and drug safety, we highly recommend it as the perfect companion to this video. Next week, we explore adverse drug reactions, classification, mechanisms, and how to predict and prevent them. Thank you for learning with PharmaconHealth, where pharmacology protects lives.